People are still coming in. I will get started as people keep coming through, but welcome everyone. Thank you for joining us today. CHPCA is very proud to be offering this webinar on how data can help navigate complex decision making with Dr. Dawn Guthrie. So some housekeeping items. Please feel free to ask questions throughout the presentation. If you can put them in the question and answer section, it just makes them easier to manage and make sure that we get to address all of your questions. If there's something you don't understand, feel free to put that in there and we can address them throughout the presentation. There will also be a question component at the end of the presentation as well. The webinar is being recorded. You will receive a link to the recording following the webinar. And we're also going to be sending you a copy of the slides, and that will also include a 2-page handout summarizing the presentation as well, if you're wanting to just have a quick refresh or share it with someone else in case it's relevant for them. So with all of those housekeeping items out of the way, I will hand the reins over to Dr. Guthrie, and I will disappear. But if there are questions, I will be popping in as a voice from the void to ask the questions throughout the presentation. So I will hand it over to you, Dawn.
Great, thank you so much, Kat. Let me just start sharing here and get everything organized. Okay, so it is my distinct pleasure to be here with you today. Thanks so much for taking the time out of your busy day to join. I'm going to be talking about dealing with complex choices in healthcare and working with some data, specific data that comes from the interRAI tools, which is what I work with almost every day. And if you're not familiar with that, hang tight. I'll get there in a minute. So I want to just first introduce myself. So I'm a full professor at Wilfrid Laurier University in Waterloo. I'm also an interRAI fellow. This research has been supported by a grant from the Canadian Institutes of Health Research, or CIHR. And I also want to acknowledge Nicole Williams, who is the full-time project coordinator who works with me, and without whom none of this would be possible. So Nicole's not here, but she certainly has been doing a lot of this work behind the scenes. I also want to acknowledge the larger team that's behind this CIHR project. So I don't expect you to be able to read everybody, but you will get the slides later. And this is our team that includes people from multiple parts of Canada and also multiple knowledge users. So you will see Laurel Gillespie there. So thanks very much to Laurel and Kat and Nick and all the folks from CHPCA who do the work behind the scenes to make these kinds of presentations possible. I ran out of space, but I also would like to acknowledge staff from Ontario Health. They have provided some feedback on the content, and it's just much appreciated. I just literally ran out of space to include everybody on this one slide. So a little bit about interRAI. So interRAI is the name of an international not-for-profit network. There's about 100 of us, and I say about because it changes quite rapidly, from roughly 37 countries around the world. And interRAI's sort of main purpose is to do international, multinational research to develop, implement, and test standardized clinical assessment tools and their related applications, which I'm going to talk about a little bit more today. There's also a link there at the bottom to the interRAI licensing information, in case you're wondering. So these instruments are copyrighted, which means that if an organization wants to use them, they need to enter into a licensing agreement with interRAI. And what that means essentially is that data that are collected also get shared with interRAI so that people like myself and other interRAI fellows can use the data for research purposes. But the key here is that these are clinical assessment tools that are used to understand the person, their family, how are they doing, what are their needs, how do we put the right kind of services in place. And today I'm mostly going to be talking about home care and palliative home care, which is the world that I sort of work in most. So although we do get the data for research purposes, the data are not collected strictly for the purpose of research. I just want to make that point. So these are the interRAI countries that are doing something with interRAI tools. There's a lot of work happening in Canada. Many parts of Canada have mandated interRAI assessments in sectors like home care, like long-term care, inpatient mental health, and so on. Not all of the countries use all of the instruments because there's a lot of different interRAI tools, but all of these countries are doing something, and that's part of what makes this work so interesting and valuable, is that things we learn in Canada can sort of immediately be shared with others in multiple countries. So this is a snapshot of some of the interRAI tools. You see down at the bottom right, it says, etc. I can't even keep up with them. There are a lot of interRAI instruments, and there's a lot of new ones that keep being developed. The ones that I've highlighted here in purple are the ones that I work with the most. So there is an interRAI home care assessment. It is mandated in Ontario for clients who are expected to receive at least 3 months of home care. And there's also a palliative care tool that's quite similar. There's a lot of overlap with the home care instrument. It is not mandated by the government in Ontario, but a lot of the local health integration networks are using it. I will also mention that many of these instruments are available in French. I can tell you that for sure the home care tool and the palliative care tool are both available currently in French. And interRAI is constantly engaging in that activity to translate the documents and the assessment tools into different languages. So this is a screenshot of the interRAI palliative care assessment form and user manual. So as I said, because these tools are copyrighted, you can't just go online and download them. If you wanted to see the assessment and really understand how it works, you would go to the interRAI website and purchase one of these manuals. You can get it in an electronic form, or you can purchase an actual hard copy and get it in the mail. So the palliative care instrument has about 250 items, and it captures these key domain areas that I've mentioned here. So the idea of these assessment tools is to get that snapshot, that sort of global picture of the person and how they're doing, and also some information about the caregiver. So when these assessments are completed, they are done through an interview conversation with the person. This is a little bit misleading because that person has a clipboard. They are not done on paper. They're all done electronically these days. But it's not a questionnaire or a survey. It's actually an interview, a conversation with the person. So the interviewers, the people doing the assessments, the assessors, I should say, get training on how to do these. They use all their interview skills. These are typically registered health professionals, so registered nurses, sometimes physiotherapists or occupational therapists might complete these in home care. And the person uses all the information available to them. So they talk with the person. They might also speak with caregivers. They can absolutely contact the family doctor or any other people as part of that care team. And then they make their judgment in terms of coding those roughly 250 items, if we're thinking about the palliative care assessment. Okay, so a little bit about the data before I actually get into showing you some data. How does this all work? So the assessment would be completed with the person in their home, typically with a laptop or a tablet, which would then be stored by that assessor. And then I'm kind of simplifying this, but all of the data for across Canada make their way to the University of Waterloo. I'm at Wilfrid Laurier, but I work very closely with folks at the University of Waterloo who house all of the interRAI assessment data. They sit on a secure server at the University of Waterloo. And then all the data are made possible so that researchers like myself and our students have access to the data and can use them for research purposes. And there's also a little link down at the bottom to a YouTube video that the Canadian Institute for Health Information put together, which is kind of nice and kind of walks through how the data all sort of come together and how they can be useful. So we have a lot of data in Canada. This is mostly the home care assessment. That's roughly 4.9 million records from across the country. And you can see varying sizes of pieces of that pie from different places. Ontario, being the largest, contributes a lot to this data set. And also Ontario has been using the assessment in home care for the longest. So that's also part of why it's contributing 3.5 million records. Okay, so let's talk about these instruments and how they can be useful for decision making. This is maybe one of the most important slides if you just want to kind of understand interRAI tools. So at the very middle, in the very center there, is you've got the assessment. So this is done electronically. Then the software gives you these other pieces. I'm going to talk about 3 of them today: care planning, health index scales, and the quality indicators. But the assessment can also be used to support resource allocation and funding decisions. So once you collect the assessment for clinical purposes to help that individual and sort out their needs, you can use the data for all kinds of purposes. So let's start then with the health index scales. So what are these exactly? Well, they're an actual numeric score for a person, as I said, generated by the software, and it helps the home care assessor understand the person's functioning, how they're doing, and their current needs. And it's used together with all the other information that's collected about the person to inform those clinical decisions. It can also help to track changes over time, because as the assessment is redone, completed in home care, it might be every 6 to 12 months that someone would do a follow-up assessment. You can use those scores to kind of see, did the person get better? Did they get a little bit worse? Or are they more or less the same as they were, say, a few months ago? So this is some examples of the scales that you get. This is not all of them, but this is most of them that you can get that are generated with either the home care assessment or the palliative care assessment. So you can see it captures things like, how is the person doing in terms of their cognition, signs and symptoms of depression, pain, and at the bottom, I will also mention there is a caregiver risk evaluation, which is a kind of scale to look at the risk of the caregiver becoming burdened, starting to experience caregiver burden or burnout down the road. So let's dig into one of these a little bit further, just so you have a handle on how these are calculated. So the depression rating scale is maybe one of the easier ones to think about. It has a total of 7 items on the assessment instrument, and each item can be scored either 0, 1, or 2 for that person. And you literally just take all 7 and add them up. Just sum them together and you'll get a score that goes from either 0 up to 14. And typically, what we have seen in the research is that a person who scores 3 or higher on the depression rating scale, that's suggestive of a true kind of clinical depression. So the depression rating scale is not a diagnosis. It's a screener to flag people who are potentially at risk of depression and are showing signs and symptoms that would indicate that they're experiencing it at this point in time. I also want to just mention another one, the CHESS scale. So this is a measure of health instability, and it includes a lot of things, which are listed here. And I'll leave that with you to go back and take a look at if you want to explore it a bit further. So the scoring is a little bit trickier because you can't just take the 9 items and just add them together. There's a little bit of decision making up front, depending on how some of these are scored. But in the end, you get a score from 0 to 5. And what we know from the research is that a higher score is very predictive of mortality. And in fact, we just finished a paper that Nicole Williams led that I acknowledged earlier on, looking at how well does it work compared to the palliative performance scale, which is something that is very, very commonly used in palliative care. And it actually works as well. So if you want to take a look at that paper at some point, there's a link there. So that's just a snapshot of 2 of the scales. And again, depression rating scale can kind of flag someone who's experiencing some issues with negative mood. You can use it to track changes over time. And something like the CHESS scale can be very good predictor of mortality. Okay, so let's move on then. Now that we've done that, let's move on to care planning. So we have what are called clinical assessment protocols, or CAPS for short, that again, the software will tell you which of the CAPS are triggered for a person. So the CAPS include many, many different domain areas, including cognition, mental health, social life, clinical issues, and functional performance. So let me walk you through kind of how this works. It's a bit like putting together a bit of a puzzle piece. So there's a number of items in the instrument that act as triggers to the CAP, or flags, again, generated by the software. So nobody has to figure this out themselves by going back to the assessment and trying to figure out which items might be triggering. The software does that. So once the assessment's completed, the software actually generates a report. It's typically sort of a one-page report in the software that shows which of the CAPs were kind of flagged for that person. So it's telling the assessor whether things like pain are an issue for this person, or shortness of breath, or maybe symptoms of depression. And then along with that information is a manual, so that the assessor has something to refer to. It's not prescriptive, so the documentation doesn't tell you, if you see this, you have to do the following. It's a guideline. So it will suggest possible referrals, maybe some other information you might want to collect, maybe some other assessment you might want to do. It's there to guide the assessor in terms of, what do I do next? Now that that CAP is triggered, what makes sense? So this is kind of how it would naturally kind of flow in the real world. The CAP list would come through the software. The assessor would look through that list. They would kind of think to themselves about whether they feel as though it's clinically important and relevant for that person. They would typically also have a conversation with the person and or their caregivers to ask about what are their priorities. So it's a shared decision-making in terms of, what do we address first? Many clients in home care will trigger multiple CAPs, so maybe 5, 6, 7 or more CAPs. So there has to be a bit of a process of sorting out, where do we start? What's most important clinically? What's important to that person? So at the end of the day, there definitely is some choice on the part of the client in terms of, what do we do next? And it's in conjunction with that assessor. And so this is a snapshot of the manual. So we have a manual for the assessment tool and how you score it. And then there's a manual with the CAPS, which again, you can get electronically or you can get a hard copy. And so the CAPS include things like fatigue, shortness of breath, problems with sleep, pain, delirium, and so on. This is just a snapshot of some of the CAPS, not all of the CAPS. Okay, so I did promise you we were going to talk about 3 of the 4. So let's shift gears a little bit and talk about these, the quality indicators. So I have actually been working on these for palliative care for quite a number of years. We're actually, I think, into about year 7 or 8 at this point of developing some quality indicators based on interRAI data. So this is near and dear to my heart. So what exactly are these? Well, they're quantitative values. So you get a percent. Typically, we express them as a percent, and it gives you a sense of how frequent an issue or a symptom or a problem is happening in a group of people. So the scales and the CAPS are for one person, for an individual like me. I would have scores on the scales. I would have CAPS that seem relevant for me. The QIs are a bit different. We don't generate the quality indicators or QIs. I know there's a lot of acronyms. So feel free to ask if I've used one that you're not familiar with. So the quality indicators are for a group of people. So it could be an entire home care program, say in the last year, or a palliative care team in a particular region. It could be for a country, but you roll the people together into a group, and then you measure the QI for a group of people. So you might be wondering why the check engine light. So these are not definitive measures of quality. And what I mean by that is just because a particular place has a high rate of pain, let's say, doesn't tell you for certain that they're doing a bad job. It's a flag. So I like to think of it as the check engine light in my car. So I don't know anything about cars and how to fix them. You will never see me pulled over by the side of the road with the hood up, looking underneath of it. If you do, you know that I don't know what I'm doing. I don't. When I see the check engine light come on, I know there's a problem. I don't know what the problem is. And I have to take my car in to someone to look at it and figure out what's going on. So the QIs are very much like that. They flag where your organization maybe isn't doing as well on some things compared to another organization or another province, but they can't tell you definitively if there really is a problem with quality. You have to do a little bit more detective work to look into that. So these are very useful for things like continuous quality improvement. So most healthcare organizations in Canada, I might even be able to say all, will go through a process of accreditation every few years. And within that organization, they need to be showing to receive full accreditation that they are engaged in continuous quality improvement, continually trying to find out how are we doing and how do we do better, and putting interventions and strategies in place to improve things. So seeing these rates and knowing how do we look this year versus last year? How do we look today versus last quarter? For instance, how do we compare here in where I live, which is in the Guelph region? How do we compare to another region of Ontario, say up north? That can give us a lot of information about how we're doing and what we want to do to improve the quality of care. So these are not finished. They are a work in progress, these quality indicators. We do have a list of 18. We're trying to finalize them over the next year. So how are these actually measured? So the math here is actually pretty straightforward. So let's look for a moment at the QI that we have for intense daily pain. How would we calculate a QI rate? So in our data set with the interRAI assessment tool, we would have the software pull out all of the people who on the assessment it said that person had intense daily pain. And then we would have our population of interest. Now we would have to decide that. So we could say, oh, let's look at how we were doing this year across our entire palliative home care program. So we would take all those clients who had an interRAI assessment, say in the last 12 months, count up how many people had intense daily pain, divide by that total, and then we usually multiply that number by 100, just so that we can show it as a percent. So as I said, we have 18 of them, so I don't have space to talk about all of them, but as you can imagine, they cover things that are clinically relevant in palliative care, like severe or excruciating pain, fatigue, loneliness, falls, and caregiver distress. That's an example of some of the QIs we have. There is a link here to a recent paper if you want to read a bit more about how did the QIs get developed, what did we do. I have also done previously a separate webinar just on that topic. So you can also go to the CHPCA website to see that if you want to learn a bit more. Okay, so now on to some data. So this is an example of one of the QIs. This is the caregiver distress QI. This is in home care among clients who are seriously ill. So I don't know if they received palliative care, because on the home care assessment, there is no item that tells you that. But we use the CHESS scale, which I talked about a minute ago, to flag or pull out those clients who had high CHESS scores and would be considered to be seriously ill and probably appropriate for a palliative type approach to their care. And you'll also notice in the upper right-hand corner, I've got a little star there saying these rates have not been risk adjusted. So let me tell you why that's important. When we are comparing different places in Canada, we know that different provinces and territories serve different kinds of populations. So that can affect the quality indicator rate. So we do a statistical sort of strategy in the background to try and kind of adjust for that, so that if, you know, let's say Ontario is serving a much older population, you would think, well, maybe they have higher rates of some of these QIs. It's not really their fault. It's just that they tend to serve an older population. So we would try and do some risk adjustment to kind of level the playing field. That has not been done here because we haven't finished the risk adjustment. We're in the process of it. We've been working on it for about a year. We have probably about another year to go to finish it. So you have to kind of take these with a grain of salt because there hasn't been any of that risk adjustment. They're just the raw values. So as I was talking, you're probably sort of looking at these numbers, and we do see quite a bit of variation. We see 48% of home care clients have a caregiver who is experiencing some level of distress or caregiver burden, and it's much, much lower in places like Nova Scotia and Alberta. Now, I can't tell you definitively why at this point. That would require quite a bit of further analysis, but as I mentioned, it could be to do with the home care program, who they typically see, who they serve, what are some of their policies about who receives home care. But I think one of the cool things for me is that we actually have interRAI data in all of these places. And it's not only similar data, it's exactly the same. So when we ask the questions about the caregiver and if they are experiencing any sort of distress, or excuse me, I need a drink, hang on. Okay, there we go. So what was I saying? So when we look at these data, we don't have to worry about, well, they kind of ask the questions a little bit differently in Newfoundland and Labrador. So we have to kind of, you know, keep that in mind. these are the exact same questions, and the assessment is completed in the same way. So we have a lot of confidence that this is measuring the exact same thing from one place to the next. And a second QI that I thought might be interesting to look at is the loneliness QI. Now, this one's a bit different because it's self-reported loneliness. There's a few items on the assessment that are just what the person tells you, and this is one of them. So it's nothing to do with what the assessor feels in that moment. It's based on what the person tells you. And now you will see a different pattern. Oh, all of a sudden, Ontario's not the highest. They were a minute ago, but now we actually see Yukon. Yukon Territory is 31%, Newfoundland's 32%, and Ontario's actually lower. And this is very typical. So I've actually been working with quality indicators for quite a while, and for probably about 20 odd years. This is something we see. It is not at all unusual for a given region to do well on some things and not as well on some other things. It's just the nature of the QIs. And I think the fact that it's really difficult for any palliative program or any home care program to do really well at everything. It's difficult. Okay, I'd like to switch gears a little bit. And as I mentioned, we did a little bit of brainstorming with some of our colleagues at Ontario Health. And I want to walk you through and share an example of how interRAI data can help when making complex decisions, specifically for looking at data that we have in Ontario. So we actually have two types of data for Ontario. We have home care data. So that's the one that I was just showing some statistics. We have it for multiple parts of Canada, and it is used all across the province of Ontario. So that's one data set. The second data set is palliative home care. So that's the interRAI tool that's specifically for palliative care. It is not mandated by the government, so different regions can choose to use it if they want to or not. But most of them do. I believe about 10 of the 14 regions use the palliative care tool for their palliative home care clients. So I'm going to talk about both, and I will kind of point you to which data set I'm talking about as we go along. So one of the questions we might ask to understand the complexities and what's happening in Ontario, the Ontario system, is, well, who is receiving palliative home care in Ontario? So this clearly is just with the palliative care data. All of these individuals, when they were assessed, were receiving palliative home care. What we know from this data set is that about 80% have cancer. We know that most of them are 65 or older. We know that about 64% of them have a prognosis of less than 6 months to live, which means the rest of them have a longer prognosis. And about 63% are married or have a partner. So I don't think I mentioned it, but in this slide, when I'm talking about palliative home care, this is about 75,000 people from all across Ontario. These statistics relate to that group. So this could be very helpful for decision makers in Ontario as they're trying to understand who is receiving the services, what are our next steps. Is there anyone, that we're wanting to target differently for palliative home care? This can be, I think, pretty useful. Another question then is, how are these individuals doing? So we know a little bit about who they are, but let's look a little bit more closely at how they're doing, what's going on. So the scales, those health index scales that I talked about, can tell us a lot. So for instance, 71% of these clients getting palliative home care in Ontario have pain, not just random, every day. And that was based on the pain scale. we can also look at a different scale that looks at activities of daily living. And from our data, I can tell you 50% of these individuals need a lot of help, not just a little bit of help, but they need a lot of support from someone in doing things like dressing and bathing and getting to the toilet. Those would be some of your activities of daily living that are captured on the assessment. I can also tell you that half of the caregivers for these clients are at high or very high risk of caregiver burden. And that's based on that care algorithm or scale that I mentioned. And at the bottom, you'll see about 40% of these clients had a high risk of mortality based on the CHESS scale. So that's how the interRAI scales can give us a sense of how people are doing. But don't forget, we also have the CAPS. So we have put together, and this is because Nicole did all of this work behind the scenes, which CAPS are triggered the most often in this group. So I'm not showing you all of them, but we tried to pick the ones that were the most frequently kind of flagged for people. So fatigue, very high, right? Almost 80% of these palliative home care clients were either experiencing fatigue at the time, or they were at risk of becoming fatigued and having that down the road. Shortness of breath is over 40%, as well as pain, mood, so signs and symptoms of negative mood, depressive symptoms was almost 40%, and issues with sleep was also high. So there's a lot of clinical issues going on, and the interRAI data can give us a bit of an overview of how people are doing in the province. Now, to sort of close out, I want to go back to that larger home care sample. So this is home care clients who are seriously ill, and we don't know if they're getting palliative care for sure, but these are all people who have pain that is severe or excruciating. So again, this information can be really valuable to a home care organization, a palliative home care organization, to understand how are we doing compared with others? How are we doing compared to last year? You can use the QIs that way. And Ontario could certainly take a look at this, even though they're not risk adjusted, and we have to be a bit cautious, but you could see, you know, there are places like BC that seems to be doing better. And this might start a conversation or a reaching out to folks in Alberta or BC that seem to have lower rates and maybe have put some strategies in place, have tried some things that are working well. We can learn from them, and the QIs might kind of spur us on to reach out. So that was a lot of information. Let me kind of summarize a little bit of the take-home messages. So interRAI tools are standardized. So if you see data from Ontario and Yukon and Newfoundland, they're captured the same way. They're very detailed, several hundred items, and they're clinical assessment tools. They're used by clinicians to help understand how the person's doing. They're widely used across the country. They're used around the globe. The home care tool is used, I believe, in something like 30 or 31 other countries besides Canada. So we have a tremendous amount of data within the interRAI network. So these data can be used not only to guide care planning and service delivery for a person, but I hope with that example for Ontario, I've helped to show that they can also guide overall planning and service delivery for a region or a province, and also they can aid in quality improvement for a region, a province, potentially even a country. So I just want to also mention, in case you haven't seen it, I will be back next week, 1 week from today, same time, the 31st, 1 to 2 p.m., to dig in a little bit to the interRAI data and some other data that we have to understand the challenges of caregiving in Canada. So I will stop there. Thank you so much for your attention, and I'm happy to take questions.
I will unmute myself. That works better. All right, great. Thank you, Dawn. And so in terms of for these tools, and you touched on it very briefly in terms of like the licensing and the copyright, but in terms of cost, how do we implement them? How do you access this these tools and see how could I use this in my organization, or how could I use this in my practice? You know, is there any kind of additional information you can provide there about cost or how to access them?
Good question. So I think the first thing would be to go to the interRAI website, interRAI.org, and there is a spot where you can purchase the manuals. So the manuals have the assessment tool and the actual assessment form, and you can also see how the individual items are to be coded. So it guides you in terms of what the assessor should be sort of looking for. That's probably the first place to start, just to see, am I interested in this tool? Is this the kind of information we'd want to, capture in our home care program or our palliative care program? And then, if an organization wants to go to that next step and thinks, yeah, I think we would like to start using it, then it would be reaching out to John Hurdy's at the University of Waterloo, or people could clearly contact me, and I could link them with the right individuals to start talking about that licensing agreement. And the costs would be something that would have to be, come from the more senior people within interRAI. I'm not part of that kind of decision making, but if an organization wanted to move on to next steps, I'd be happy to kind of facilitate that.
Okay, wonderful. And we've gotten a few questions here. So one question from Amy. Thank you, Dawn. Sorry if I missed this, but do you know if interRAI use has been implemented in Quebec much?
Not a lot, no. They are making some inroads, and I believe it's in long-term care. I don't have access right now to any interRAI data in Quebec. If anyone on the webinar is interested, I'd be very excited to talk to them, because of course we're, as interRAI people, we're always excited to share what we've been doing and answer questions and help facilitate if a group wanted to kind of look at it and test it out. Sometimes people will just try it out in a small region or just within a program. You don't obviously you don't have to have the province, roll it out across the province. But yeah, very, very little has been happening in interRAI in Quebec.
All right. Well, if anyone on the webinar is interested, you know who to contact. Perfect. So next question from Bruce. It might have been answered, but he was wondering, how would a health region receive, quote, logistical guidance if they wish to embrace interRAI de novo into their palliative care program? In terms, I'm assuming probably more on the implementation side and how they would
Right.
make it relevant.
Yes, excellent question. And interRAI has had a long, and I think it's fair to say awesome, relationship with the Canadian Institute for Health Information. They do training constantly. They have lots of resources. They have people on their staff whose job, quite frankly, is to help with implementation, with the training, with linking people with the appropriate software vendors, because of course, all of this is collected electronically, which means you have to have software. And there are multiple software vendors who are able to do that in Canada. So there are some that you can choose from. And certainly within interRAI, there are people like myself, and I mentioned John Hurdy's, who's the senior interRAI fellow for Canada, who would be, very happy to kind of connect people with the right resources. And this is, it's quite a daunting task to start using one of these and get it implemented, but we are here to help, and the folks from CIHI are amazing, and we've got a very long relationship with them, and they're great.
Okay, perfect. And we have another question. Who should be conducting those health assessments? Do you know if PSWs would be able to? Because you had mentioned a registered health professional, so they were wondering about details for that.
It's typically in home care, I can tell you, and long-term care, it's typically registered nurses, but it doesn't have to be. And I know there are some organizations where different parts of the assessment are filled out by different people. So you could have a registered nurse do the whole thing. You could have a physiotherapist do, say, the section on activities of daily living or instrumental activities of daily living. You could have an occupational therapist do it. I don't know too much whether, to be honest, whether PSWs are involved in actually completing the assessment in home care or palliative care. That I'm not 100% sure. I haven't heard of that. That doesn't mean it's not happening, but what I've heard is it's typically, nurses, PTs, OTs, maybe a social worker, to complete some of the parts of it.
Okay. And I mean, you did mention as well in your presentation that it can be filled out in conjunction and in collaboration with and after consulting with other healthcare team members. So I'm assuming as well that PSWs would be able to kind of, let's say, whoever does conduct the assessment, the PSWs could also reach out to them and say, hey, this is something I noticed. I think it might be worth including.
Yeah, absolutely. Yeah. And I have seen some research where they were, just sort of looking at that and trying to sort out what is that best mix and who knows that person the best. And the PSW certainly interact with the individuals a lot. So it just depends on how the organization kind of structures that.
Okay, great. Thank you. And we have another question here from Teresa asking about whether hospices are using interRAI as well.
Not that I'm aware of. I would be thrilled if I could say they were, and I'm totally on board with creating something. But to be honest, and I've been in contact with multiple hospices and work closely with them on some of the QI work, both in Canada, in New Zealand, but also in different parts of outside of Ontario. The current assessment tool for palliative care, remember, it's about 250 items. What I heard loud and clear from people working in hospice is too long. And there's a lot of stuff in there that by the time someone's in hospice, it's not really relevant. Certainly people are doing assessments in hospice, but we probably need a different tool. We probably need something that's more geared towards someone who's in hospice and typically has that shorter length of stay. And at that point in time, some of these things they're not relevant anymore. So why are we asking people about them? So I have sort of said to people, how can I help? Would you like to work together to do something? Because I'm quite happy as I am the interRAI person who oversees everything related to palliative care globally. So it is kind of on my to-do list, to be quite honest. And so I'm happy to do it, but I would need help, right? I would need people who work in hospice to say, Dawn, we need these things. These other ones over here, no, we don't ask about that. We don't need that. So yeah, I'm willing, would need help.
Okay, great. And actually, as a follow-up to that, could the interRAI data be used to assist decision-making about admission to hospice, for example?
Oh, most likely. Yeah. Again, I think that would be terrific and it may be happening again, there are home care programs who are using the palliative care tool and would be using some of that information to decide what are the next steps for this person, and is the home the best place for them? Would they be better going to a hospice? I remember not too long ago talking to a couple of palliative care physicians who work at the Temi Latner Hospice, and they go to people's homes as part of their hospice service. And so we were talking about, what assessments they do. Would an interRAI type tool be useful? Because they weren't familiar with them, they don't use them, but they do assessments. So I think the short answer is yes. I would like to feel as though whatever is captured for that person in their home as they're getting palliative home care could set up, and inform those decisions about what's next, including whether hospice would make sense.
And I imagine as well with these home care assessments, when they're kind of flagging these caps as they come up, if as the team is trying to address some of those issues, they're prioritizing, because like you said, in home care, there's often multiple things happening all at once. I would assume as well, and correct me if I'm wrong, but if there are multiple caps happening, multiple things going on, and maybe in home care they're struggling to try and get a handle on all of these things as they come up, it might also help to have these assessments to show, okay, we have these things that are reoccurring and we're trying different things to manage them, but it's not being managed, and kind of give a bit of that context and kind of show, okay, we've made progress, maybe we haven't made as much progress, and we need to maybe look at something a bit more drastic in terms of changes in approach. So I would assume as well, it could be helpful with kind of providing a bit of that objective look back, and seeing what strategies have been working or haven't, and maybe provide a bit of that additional context to make sure that people know what interventions are maybe needing to be considered.
Right. No, absolutely. I totally agree. And I would just add, and in conversation sort of with the person and their family, because things change so rapidly. So, as quickly as you did an assessment, things could have changed. So it's that idea of kind of reassessing, checking back in, what are the priorities? Are they the same as they were? Or, do we need a different strategy? Do we need to bring in different people with different expertise? And I think it's kind of a good news story, that people getting palliative home care in Ontario, that 80% have cancer, but that means 20% don't. So there's actually quite a number of people getting palliative home care who have some other type of diagnosis, have maybe a longer prognosis. They're not imminently dying, but they're getting palliative home care. So I think that's one of the things I took away from some of that analysis.
No, absolutely. And, we see that with in the recent CIHI report, showing that people who receive palliative home care typically receive palliative care much longer than people receiving palliative care in other settings. So I think that indicates there's something there that is working, at least on that front, of making sure we have more palliative care for a longer period of time for folks, so they can have that care for quality of life. All right. I'm just trying to see if there are other questions. One just came in. Have there been publications specific to caregiver or patient acceptance of the palliative care assessment instrument?
I don't know off the top of my head. So sorry, can you say the question again?
Have there been publications specific to caregiver or patient acceptance of the palliative care assessment instrument?
Not off the top of my head. I haven't. Doesn't mean that it's not out there. I can't think of a paper that's been published sort of asking specifically the caregivers and individuals kind of what they think about it.
Okay. All right. Potential future research topic if someone on the webinar is interested in involved in that kind of research. I do remember you were involved in some interviews and more qualitative approach research with caregivers as well. Was there anything in there that talked about what that process and these assessments, or what caregivers felt about the palliative home care, or any kind of assessments that were done through that process?
So we didn't really ask people about the assessment itself. We were asking them about, and this is some of the stuff I'm going to talk about next week, so I don't want to let the cat out of the bag. We were more talking about their experience through that palliative journey. So they may have talked about in their interviews that assessment piece and their experiences with that, but that wasn't really the focus. The focus was sort of on, did you receive what you consider to be good quality of care and why, or what were the challenges? Where did things kind of fall apart? And we did publish a paper on that, but it wasn't focused on, what did you think about the assessment? And for some of these people too, it might have been a year or two previously that they had had the assessment. So it might have been a bit tricky to ask them to go back. Yeah.
Yeah, and it can also be hard because especially with palliative home care or palliative care in general, asking people to participate in these research studies about what was your experience when in this, when it's already a very overwhelming experience, is always a challenge. So we want to be respectful and mindful of that, while also we want to make sure that these assessments are not accidentally creating additional barriers. But well, we are nearing on time, and I think that we have, if there are any last minute questions, please throw them in here. Otherwise, I just want to also close off and say thank you very much. This was wonderful. And for anyone who is interested on better understanding the caregiver experience and the challenges that caregivers in Canada face, there will be, like Dawn mentioned, a webinar next week, same day, same time. So June 7th at 1 p.m. Eastern time. We will hopefully see many of you back here to talk about how this data is providing more insight into the caregiver experience. We're seeing a couple of people thanking you, Dawn, for the presentation.
Oh, my pleasure.
And so, well, thank you very much, everyone, for attending. On behalf of CHPCA, just thank you to Dawn. Thank you to everyone who participated for your questions. And we will see you next time. And hopefully we will see you next week as well. All right. Thanks, everyone.